We'll turn the session on to Dr. Joanne, the director of the UCLA Aggie Hirshberg Center, and to Tim Donahue, who is the head of our surgical oncology program at UCLA. So, Joe, it's all your show. I'm turning the table now to Joe Hines.
Good morning. So far, this is an amazing morning. Everybody here talking about their stories, Dr. Pandal, Dr. Temporo, talking about Aggie's contributions and hearing from Dean Martin. You told me to stop talking about your Aggie? Cut it off? Okay. Dr. Donahue and I have been tasked with telling you a little bit about our center at UCLA. And I'm going to talk about contextually some philosophy where we find ourselves within our community and how we think about the program, and that Dr. Donahue is going to talk more about the specifics of the program and some of the exciting research that's going on. I also wanted to recognize my mentor and really at least on the surgery side, the person who was the genesis for really in many ways why we are here today, and that's Dr. Howard Reber. Dr. Reber taught me how to care for patients with pancreatic disease, taught me how to do these operations, taught Dr. Donahue also the same. So he's been a very important part of pancreatic cancer care at UCLA since 1989. Is that right, Dr. Reber? 87? You're not quite sure. Okay, we won't count. We won't count this morning. Okay. I'm going to talk a little bit about surgery and let you know that the first surgeon to ever perform a Whipple operation was not Dr. Whipple. This is Alessandro Codavia. He was a professor of surgery in Bologna, Italy. He wasn't even a GI surgeon. He was an orthopedic surgeon. All right? And he did the first resection in 1898. Patient died 24 days later. He never did another one after that. So if you think about that time and where we are today, the tremendous progress that's been made in the world of surgery for the pancreas, it's really been remarkable. This is actually an intraoperative image of one of Dr. Reber's surgeries of a patient who's had a Whipple operation. And I'm going to try to orient you here. I'm going to use the pointer. So this right here is the head of the pancreas. This is the duodenum. And the neck of the pancreas, there's some sutures in the pancreas. This is the body and tail. This is some of the big vessels that we worry about that live next to the pancreas, the superior mesenteric vein, the portal vein, the common hepatic duct. There's a clamp on that. And then if you just took a square here, we're going to take all this out, and this is what we're left with here. This is the cut edge of the pancreas, and the portal vein, and the hepatic artery, and all the tissues surrounding. And we can do this operation pretty well now. Patients have good outcomes. If we routinely tell our patients, gosh, in about 6 to 12 weeks, you're going to be back to pretty normal existence, eating, being able to go out to a restaurant, do a lot of the activities that you would usually do. It's still a big operation, and there are things that can happen. This is actually an intraoperative video of doing some of the, let's see if it's going to work. Not going to work today. This is so classic for videos on a PowerPoint slide. But this is just showing a video of what goes on when we sew the intestine back to the pancreas. So as surgeons, we're really focused on technique and outcomes, but we really see a very small percentage of patients with pancreatic cancer, because only maybe 10 to 15% of patients can go to the operating room. Most of the time, patients present with systemic disease, already metastatic disease, and it doesn't make sense to take out this tumor that's in the pancreas when they have tumor and tumor cells in other places. And The philosophy of the center at UCLA has really to be more in tune with the entire arc of the care of the patient, and it includes how patients touch so many different specialists, caregivers, staff, and try to roll that up together as one experience. So, it's an overwhelming situation to be given the diagnosis of pancreatic cancer. We want to be able to shepherd that patient through this experience, provide the best care. And this is think about this beautiful university we're sitting on. This is a photo of Royce Hall, circa 1929 when it opened. And we're just a few feet away from that here in this beautiful new conference center. The first chair of our department was Dr. William Longmire. Dr. Longmire was also a pancreas surgeon. He did a lot of different types of surgeries, but it was really Dr. Longmire that made popular this thing you may have heard, a pylorus-preserving pancreaticoduodenectomy. So you preserve all of the stomach. So pancreas surgery has always been a big component of the Department of Surgery here at UCLA. And now here we are sitting in this beautiful city, the campus and the health system on the campus. And we have a large population that we need to be sure that we take care of, that when a patient comes with a difficult diagnosis and drives all the way to our medical center, which is not always easy and confusing and big and overwhelming, that we provide the best and simplest and most caring treatment plan possible. In academics, we have to pay attention to a lot of the different components. In fact, it's kind of a privilege to be able to have all these different parts of what we do here at UCLA. We're taking care of patients all the time, every time, and striving towards excellence. But that care is advanced with the research that's done, and we are obviously training those who are going to be the next generation, and we're doing this all within the context of our community. And you may or may not know now that UCLA is more than just here in Westwood on the UCLA campus with a wonderful Ronald Reagan Hospital, but UCLA has spread all over the LA basin, now over 170 clinics, and there are medical oncologists all over Los Angeles. And so the Pancreas program at UCLA connects these in a way that if you're seen by medical oncology in Santa Clarita, there's a clear connection between that oncologist and the treatment team at UCLA in the Aggie Hirshberg Pancreas Center. It's confusing to be a patient. We want to think of them as a whole individual and just not as a surgeon mentality that there's a lesion in the head of the pancreas, so we're going to take that out, and we know all the techniques to be able to do that. The center now involves a lot of different important components, including things like palliative care, genetic counseling. Annette's going to be speaking next about her area of expertise. This group is intimately involved in the clinic every day in providing support and counseling for our patients. That we really provide the full array. It's our thought that if you do that, the outcomes are better medically. And actually, there was a really interesting study that came out not too long ago, and Aggie was highlighting this at the last meeting, where patients who had regular follow-up from nurses, and then there was some output from that. You get a phone call and something's going on, you're 6 months out, 9 months out. There's actually a survival advantage for the patients who have pancreatic cancer who got that really intensive, full-scope care. So that's the goal of the center at UCLA. We all know now that largely we are seeing patients in this part of the curve all the way out when they already have metastatic disease. We know that pancreatic cancer, the first cancer cells or the changes in the cancer cells happen 20 to 25 years before the onset of the symptoms when you come to see a patient. And what we want to do is move this in the direction like has been done for breast cancer, where we see patients who have early disease and we have more effective therapeutics in that situation. And in time, we're going to get to the place where Dr. Pandal talked about, where we have patients who have precursor lesions, not yet cancer yet, but we're going to put them on a statin or we're going to do surveillance, or we're going to do other types of therapies that a lot of scientists across the country and really across the globe are focusing on. The nice thing about the center that we have at UCLA is that not only is it about the patient care, but it's about moving that curve too with the research that's being done. Dr. Donahue is going to talk more about this concept of an integrated practice unit. I'm not going to talk too much about the details, but an integrated practice unit is a fairly new model that's come on board over the past few years, and it's the idea of bringing a group of experts around a disease. So it's not the surgeon off down the street seeing the patient, the medical oncologist seeing the person on another part of the campus, and they might communicate by an email. It's really about bringing everybody together who touches a patient with this diagnosis, and everybody meeting regularly, looking at outcomes and talking about new ways that we can care for our patients. The center is large. These are 2016 statistics. We saw about 750 new patients, most of these for cancer. We do between 140 and 180 pancreas surgeries a year. Dr. Donahue is one of the busiest pancreas surgeons really now in the country. We have new faculty that have brought new technology, and now we are doing robotic pancreatic surgery. And this is the largest center like this for pancreas west of Colorado. So it's a really wonderful testament to all the work that Aggie has done. I want to introduce my colleague, Dr. Tim Donahue. Tim trained here at UCLA. He's a surgeon scientist, and he is the new chief of surgical oncology. He wears a lot of hats. He's also the residency program director. He just moved into a new house. He has 3 kids that are tiny. And I don't know, Tim, lots of coffee, I think, lots of coffee.
Thank you, Joe. Thank you very much. None of that would be possible without the opportunities that you have given me. You said that Howard's a mentor. You're also a tremendous mentor. One other person I wanted to point out who's been here today and has spoken is Kelsey Martin. She's an incredible dean, and she's also very committed and dedicated to committing resources to cancer, very much so. And after a bit of a process, she's committed to giving resources to pancreatic cancer at UCLA, including up to 4 faculty hires with attractive packages in order to do groundbreaking research here. So I'd like to give Kelsey a round of applause because of her dedication to pancreatic cancer. Thanks, Kelsey. All right, so I'm going to talk about our team approach to pancreatic cancer and diseases at the Aggie Hirshberg Center for Pancreatic Diseases at UCLA. We'll start with the clinical care. I know there's a lot of words on this slide. I don't really like a lot of words on a slide, but I'm just going to go over a few key points. Dr. Hines talked about the integrated practice unit that we have at UCLA. I just wanted to point out a few words in the definition of an integrated practice unit, but it's a dedicated team, and we certainly have a very, very, very dedicated team here, hoping to provide efficient and comprehensive care. I think this is important. IPU members have got to love each other. They got to live together. They got to meet frequently in order to try and improve their clinical care for specific diseases, and in our case, pancreatic cancer. Co-locating doctors in a multidisciplinary clinic is just one component of an integrated practice unit. The specific goals of our integrated practice unit for pancreas diseases or pancreatic cancer at UCLA are to work together as a cohesive team, provide efficient value-based care, perform rigorous evaluation of our outcomes, integrate our science into our clinical care and expand enrollment in clinical trials, and ultimately increase the number of patients we see and treat at UCLA because we think we give them the best state-of-the-art care. This is a schematic of our clinical workflow, so to speak. I know my wife disagrees with the colors that were made here, but I just what I wanted to say and point out is that she's much better at me at these things. To say that we meet in our tumor board in our multidisciplinary clinic, or multidisciplinary conference right before we go to clinic. And the experts who are there are members of, surgery, oncology, gastroenterology, radiology, genetic counseling, as Dr. Hines said, radiation oncology. And we all meet in a conference and we discuss all the patients who are coming to clinic that day. And then we all walk over together and go to clinic together and see those patients with each other. It minimizes the amount of time that anyone has to forget what was just discussed about any of the patients. We serve lunch, so everyone shows up. It's an optimal schedule and model in order to enroll patients in clinical trials and provide them with the best, most state-of-the-art multidisciplinary care. We were supposed to talk about, or we're talking about, the team approach to pancreatic cancer treatment. This is from the National Comprehensive Cancer Network guidelines. I mainly put this here because Dr. Tempuro is the head of the committee, but she left before seeing the slide. But nonetheless, we'll think about her, and one of the main components of it is a multidisciplinary review, right? So team-based approach to pancreas cancer or pancreatic diseases. An inherent component, an important component, is a multidisciplinary review. And I wanted to show you a few examples of why that's important and how we're doing really well at it at UCLA. This is a treatment schematic for patients with borderline resectable or locally advanced pancreatic cancer. And you can see here, and many of you have probably experienced this, but they undergo staging and then chemotherapy or radiation therapy and then maybe another CT scan and then surgery or more radiation therapy. And so there are many ways to so-called skin this cat or peel the onion. And so it's important that there is a multidisciplinary discussion with providers from different expertise in order to design and chart the optimal treatment approach for every single patient. Because the treatments have become more, because they've become more diverse, because they've become better, has made this algorithm even more and more complex and complicated. Here's another example. This is not pancreas cancer, but it's an example of why multidisciplinary approach works well. So this is actually taken from some clinical trials of patients who have colorectal liver metastases. So colorectal cancer that is metastasized to the liver. And you can see here, it's a study with EGFR inhibitors, and the response rate, the percentages across these 4 different trials is similar. So response rate is 71%, 76%, et cetera. But if you look down here, so the resection rate, so the microscopic margin negative resection rate improved markedly from the trials from the left to the right. And why is this the case? If you look at the design of each of the studies, I think it becomes evident. So the first few, the patients were recruited by general oncologists. But the second two was multidisciplinary treatment, including a liver surgeon and also oncologists. Who determined liver resectability? The first two general oncologists, the second two multidisciplinary tumor boards with the oncologist and the surgeon. So just an example of why multidisciplinary treatment or approach to cancer or complex cancers or cancers with multiple different treatment options is important. I'm sure this exists for pancreas cancer too, but there's no specific studies that I'm aware of. This is our clinical trial portfolio. I said that the integrated practice unit is the optimal treatment model in order to incorporate clinical trials into treatment of patients or to offer them. And we have a really great, well-balanced portfolio of trials for our patients. The ones that are highlighted here are immunotherapy trials. So you can see that we do offer many trials with immunotherapy. The one on the top here This is a Parker Institute or Parker Center trial. Sean Parker has given money for studying immunotherapy for cancers and to select institutions, UCLA being one of them, thanks a lot to the work of Dean Martin. And we are able to leverage that network in order to offer an immunotherapy state-of-the-art trial for many of our patients. This is our high-risk screening protocol or surveillance protocol, whichever you want to call it. But we have, as I said, genetic counselors. We've got a clear algorithm on who we think should be screened. BRCA-positive folks with one family member with pancreas cancer, I think that is a person who would be eligible for our high-risk screening protocol. But what I'm saying here is another resource that we have developed at UCLA for treatment of patients with pancreas diseases and pancreatic cancer because of our multidisciplinary team-based approach. Okay, talk a bit about pancreas cancer research at UCLA. These are all the places where it takes place. We have spread our footprint across the south side of campus. We have a California Nanosystems Institute. We have a Clinical Translational Scientific Institute, the Broad Stem Cell Center. I'm sure Dr. Martin could probably give this talk better than me. Hirshberg Foundation has been invaluable at launching all of these efforts that are going on. Our cancer center here, as I talked to you about the Parker Institute for Immunotherapy, we're one of about 6 centers or so that participate in this. The Amundsen Translational Imaging Division, of which I am a member, and the Department of Molecular Medical Pharmacology, too. This is an overhead picture. It's an outdated one. This building isn't even on there. But of why this is all possible and how we're all so closely located to each other in all these different institutes, including the hospital, which is right across the street. There's tremendous collaboration that goes on from the school and the hospital, and it's really a bona fide academic medical center, and these efforts enable us to offer our patients even more state-of-the-art care and treatment. This is a snapshot of the research that's being done at UCLA for pancreatic diseases, again, many of which was made possible from seed funding by Aggie Hirshberg. I've highlighted a few names here, not because it's mostly me, but because I gave this, I forgot to unbolden them, I really did. I tell you, my wife is a lot better than me at this kind of stuff. But I gave this talk at the University of California Consortium meeting 2 weeks ago in San Diego that Dr. Tempuro talked about, and these were the people who attended the meeting. That's it. But anyways, we have funding on targeting diet-induced promotion of KRAS-initiated pancreatic cancer. We have a U01 on developing a nanoparticle platform for pancreas cancer. I showed you the molecular medical pharmacology or Amundsen imaging division. We have an R01 on PET imaging guided personalized treatment therapy for pancreas cancer. We can image gemcitabine metabolism, which is the most common standard of care given for pancreas cancer, to identify people who we think are responders if in fact their tumor lights up with this gemcitabine analog PET probe. We're now starting to look at nucleotide metabolism in pancreas cancer. We submitted an R01. We got a 9th percentile, so hopefully that's optimistic. And it definitely should be funded, but I don't know if it's going to be funded, but we're going to keep working on that. We have money from the Keck Foundation and a lot of other grants and research that's being done. I think this is another good example or slide to show the research productivity that's being done at UCLA on pancreas diseases and pancreas cancer. This is just a graph where you can see the number of pancreas-related publications between 1980 and 2017. 2017, we had 59 pancreas cancer patients. No, we had many more pancreas cancer patients than that, but we had 59 papers compared to 12 in 2007. Many high citation publications and very impactful journals, and we've had multiple pancreas cancer-related intellectual properties that have been filed and licensed both in nanotherapy and also a nucleotide mimetic small molecule that we are developing now in the laboratory. UCLA and advancing cancer therapies. This is a little rah-rah for UCLA. Again, I think Kelsey could probably give this a lot better than me, but nonetheless, it's a tremendous institution, right? This place was only founded in 1919. I grew up on the East Coast. My high school was founded in 1840, so much before UCLA. But this is kind of a snapshot of UCLA, 43,000 undergraduates, graduate students, 42,000 faculty, administrators, and staff. 2016 research awarded was about $1.05 billion, a tremendous portfolio budget for research. At least 7 faculty Nobel laureates. We have a CTSI to enable scientific research, and we now have 2 SPORE grants at the medical center for prostate cancer and brain cancer, and hopefully for pancreas cancer. We're poised to change the standard of care for pancreatic cancer and other cancers, and to really push the field forward, not only because of the research that I showed you that's being done specifically for pancreas, but also because of the resources and infrastructure that we have here at UCLA. This is our Chief of Medical Oncology, Dennis Lehman, who has been very instrumental at developing a network for clinical trials. You can see both in the Southwest and across the country, and also across the world, right? So it's very easy for us to enroll patients in clinical trials, whether they be, institution-sponsored, industry-sponsored, investigator-initiated trials, because of our broad reach, and again, very, very poised to advance this disease and change the standard of care. These are some other hallmark achievements of UCLA. In the last few years, there's been 4 drugs out of this institution that have been FDA approved for various cancers. Pancreas isn't on there yet, but it's going to be on there. We're going to continue to work to put it on there. But this is a something that many other institutions cannot boast, and is possible largely because of the tremendous cancer-related network that we have here. So think about this in combination with our pancreatic cancer, pancreatic diseases integrated practice unit, and the research that's being done, the resources that are being given by the dean. We're going to do it. So this is a report from the Milken Institute down the street in Santa Monica on commercializing work or research that's been done at institutions and universities. UCLA is doing really good at this too, so we've been able to commercialize our research, our intellectual property. You can see we're ranked number 15 in the country, but we're ranked number 1 in startup companies. So our faculty, investigators, myself included, are good at taking their research, developing avenues, pipelines for which it can be put into treatment and trials for patients. So to summarize here, UCLA Pancreatic Cancer Program, we're poised to move the field forward. We are very much so poised to move the field forward. We have a really robust clinical volume. We have a team-based approach, a very collaborative approach. We all like each other. I think we'd still go to the meeting, even if lunch weren't being served. Predominantly because it's for you. So many of you who I know, so proud of you. You're all my heroes. We're ideally designed for clinical trial enrollment at UCLA for the research that we do. We have a really active and well-funded research program in pancreatic cancer. Our strengths include nanotherapy, imaging, inflammation. Guido Eibel's in the back, he was in the back, who's looking at obesity, fat intake, inflammation, and pancreatic carcinogenesis. We're getting really good at nucleotide metabolism, drug discovery, so treatment therapies for pancreas cancer. At UCLA, the institution here, and the David Geffen School of Medicine, very resourceful environment, and an extremely strong track record for translational research. So at the end of this, I ask, why would anyone want to be treated for pancreatic cancer other than UCLA, particularly in the city of Los Angeles? So In the end, this was a cover of Time magazine and Forbes magazine with articles that were focused on immunotherapy. But hopefully someday these headlines will be for pancreas cancer drugs. I don't want to put this here, but hopefully for a drug that's discovered and developed right within our own institution here and for our own patients here. So with that, I'd like to thank you for coming today. Again, as I said, you're all my heroes, and it's my pleasure, privilege to be able to present this to you. Thank you. Questions?
Hi, Doctor. It's
How
good
are
to
ya?
see you again.
Yeah, you
thank you
too.
so much, and your whole team for all the awesome work that you've done for our family. But I'm sure there will be a patient panel later on. I'm looking forward to meeting all of you who may also be patients of Dr. Donahue's. I wanted to know whether or not you had any consensus at the Pancreatic Center at UCLA about whether or not weakening the stroma or it leads to metastasis or helps the chemo.
Yeah, right. No, that's a good question, right? So, there have been a few stromal targeting agents that have made it to pretty advanced clinical trials for pancreas cancer. The first was out of work done by David Tuvison, who's now at Cold Spring Harbor, who found that hedgehog signaling was thought to promote stromal development and stromal biology, in a paracrine interaction from tumor cells to fibroblasts. Really great science, really great mouse models. And so they started a clinical trial with a smoothened inhibitor, which inhibits hedgehog signaling in fibroblasts that was in a phase 3 trial. It hurt patients, did worse. The second trial that's being done for patients, stromal targeting is hyaluronidase, or this PEG-PH20, to try and kind of digest up the stroma, right? Hyaluronic acid is a glycoprotein or carbohydrates that is thought to generate or cause a lot of the dense stromal architecture limiting drug delivery. And from what I've seen and heard, the initial results from that trial aren't so great either. It may be good for patients who have high levels of hyaluronic acid synthase, so kind of a biomarker to direct the treatment or the care going forward. So while the stroma is an attractive thing to target, we haven't really done it that well yet. But I do think that there should be continued work doing it, good science doing it, and these trials really developing or generating out of good science as the justification or rationale to do them. So yes, it's a good concept. Unfortunately, the initial experiences with it aren't as good as what was initially thought.
One fast question. Could you explain to us why publishing is so important?
It's our job. Maybe we could ask the tenure committee. No, I think it's important. It's important because it's the way that we communicate as scientists, right? So it's a way that we present our results, we broadcast our results, we broadcast our findings, we publicize our findings. I mean, that's kind of inherent in the definition of publishing. But it undergoes strict peer review, and so it's stamped or made sure that it's done well, and it's science. It's the way that we communicate our results, and I think it's extremely important to do that. I think it's an absolute stepping stone. I think that our ultimate goal is to treat patients better, right? So that's what we're trying to do. That's why we're trying to do this work. That's why we're trying to merge clinical and research and translational research. And that's why Kelsey's trying to have people in the hospital talk to people in the medical school and work together and recruit people jointly together. It's to help have that science drive treatment and revolutionize care and move the field forward. But inherent in that process is also publishing and letting the larger community know about your results and not just keeping them within your own hard drive.